We are starting with what we are calling the inaugural Anne Crichton Lecture, going to be delivered by Dr. Fiona Clement from the University of Calgary. But first, I'd like to provide some background into this, into the lecture, named after Dr. Anne Crichton, who was a professor at the University of British Columbia. And this award is in memory of her in a foundation set up by David and Ruth Sue, and they have provided us with the motivation to have this lecture to focus on the memory of Dr. Crichton. And you can go to ResearchGate and find her publications. She preceded my time at University of British Columbia, but she did a lot of work in terms of very front-running problems in the health system, thinking about capacity and health services planning and policy solutions. So we have a lecture in memory of her, and we thank the Sue family and the foundation, and also the family members of Anne Crichton who are here today. So I'd like to ask Dr. Clement to come up to prepare to give the lecture, and also the discussants who will be, zeroing in on things that Dr. Clement mentions. And with that, I'll hand it over. So thank you very much.
Thank you, Jason. Those of you that know me know I have a ton of paper up here, so give me a second. So I just wanted to open by sharing how meaningful it is to be offered this inaugural lectureship in recognition of Dr. Crichton. It's incredible for me to be up here speaking in recognition of someone who was so well respected and admired by many people that I respect and admire. And it is very humbling, and I'm not gonna cry, but it's very meaningful. So I wanted to open with that. I also just wanted to note that part of why the Sue family decided to do this is because of the impact that Dr. Crichton had on Dr. Sue when he was training. And also just picking up on that, I think in my other hat as an educator who has the privilege of working with students on an annual basis and engaging with them through that time in their life. Again, just an incredibly meaningful day for me today. I took the lecture part of this inaugural event very seriously. So I hope that this sort of takes you back to the last time you were in a classroom, sitting with those terrible, terrible little desks that you're not big enough for you to have your notepads on. But I'm very excited to be here today. I did want to just open by acknowledging that home for me is in Calgary, which is on the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Pekainai, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. And the city of Calgary is also home to the Métis Nation of Alberta Region 3. And I have the privilege of having an office that looks west, and the whole west side of the building is glass. And so whenever I'm working on something and I'm a bit stuck, I can just leave my office, go over, look at those beautiful, beautiful Rocky Mountains that are so inspiring. And I just feel so privileged to be able to work on that land, raise my family on that land, and play on that land. So Dr. Crichton, as Jason said, was doing a lot of her writing about the Canadian healthcare system in the 80s and the 90s. And I wanted to share with you a piece that she wrote, and I'll just read this to you. This came out in 1985, so right around the same time as the Canada Health Act. And she writes this opening summary of her piece is saying, is downsizing the latest jargon word applied to rationalization a new concept or different manifestation of a long-term trend in health services management? At present, Canada is struggling to implement feasible reductions of expansionary pressures in the healthcare system. While provincial governments tend to see the issue as one of controlling chronic excess demand, federal governments tend to see the issue as one of access to care on an equitable basis. Thus, the problems of downsizing can be expressed by the provinces in terms of an ideological struggle with an unfeeling central government which does not understand their problems, although they know that they're really about the feasibility of continuing to provide a service to meet demand. I hope that sort of resonates with you about the conversation we're having now. And when we think about that in today's language, the argument might go something like, Healthcare costs in Canada continue to rise. Healthcare spending has now reached $265.5 billion. That's an increase from the 5.2% in 1981 to 11.5% of the GDP in 2019. Represents 35 to 50% of each provincial budget. And increased spending on healthcare comes at the cost of other social spending. And this is leading to increased calls for change, and the value-based care agenda is coming out of this. So just to say that this is very familiar ground for us in a policy context. We've been in this kind of conversation before, and I hope we'll never be in this kind of conversation again, but I'm not sure on that. So an overview of what I'm going to talk about. I'm going to start by talking a little bit about a goal, and then I'm going to switch focus to talking about some data. And then I'm going to talk a little bit about just getting on with this. As I said, we've been talking about this for a while. So I just want you to take a moment to reflect. Feel free to close your eyes if that helps you, but please don't fall asleep on me. That might have been your undergrad experience. And I just want you to fill in the blank on this sentence. The goal of the healthcare system is. Okay, and I'm going to ask some of you to throw your answers out. Thank you, Milan. Anyone else? Thank you, John. From the back, come on. This is reminiscent of the last time I taught. No. And my students know, I'll just wait them out. They talk eventually. Come on, one more from the back. Ah, thank you. Thank you. So even in this, very systematically biased sample of people that we have in this room, 3 very different goals thrown out, and I would guess that each of you had a slightly different goal. And I just want to challenge us to say that, sometimes people might say maximize the health of the population. But I think when you reflect on how we actually spend our money in our healthcare budget, that very clearly is not the goal, because we're really focused on acute care services, which tend to help people become well after they're sick, rather than maintaining the population health. So I think we might also say things like act as good social stewards, offer good care in a cost-efficient manner, maximizing qualities. But I think when you look at how we're actually spending our budget, you could probably poke holes in all of those goals and recognize actually the way that we've designed our system doesn't match achieving any of those goals particularly well. So, as we heard about yesterday from Joanne and Geneviève, the triple aim has been put out there as a goal of a system. And there are multiple different versions of this out there. But what I want to challenge you to think about is when you look at these words, population health, experience of care, and per capita cost, which is the original language of the IHI triple aim, you can see these different concepts drawn out in different ways in the Canadian context. So sometimes we change that per capita cost to better value. Sometimes we change that experience of care to patient outcomes specifically. And sometimes we change that population health pillar to equity. And so even here, where you think about, perhaps very clear words, I don't think we have great agreement on what these concepts mean and how we could adopt this to guide us. It gets even more confusing when you move into the quadruple aim, which adds some layer of provider or clinical experience, again, initially conceptualized as joy for clinicians in their work life. And we've modified that language. I think today you might see words like preventing burnout and well-being of providers. And notice here again, the language has changed. So lots of kind of amorphous concepts, even though we kind of throw out this triple aim as our goal. Taking it even further into the quintuple aim, where we add in equity, again, changing the language. And I think we're really stuck on this idea of multiple goals. Of course, our system would have multiple goals, but there's really nothing here that we could line our resource decisions up to. And thinking back to Joanne's wise words yesterday of when you have a mission and a vision, then you can allocate resources against achieving it. When you don't know what you're doing, it's very hard to do that. And as the Cheshire Cat said to Alice, when you don't know where you're going, it doesn't much matter which road you take, right? So again, of course, this conversation is not new, and it has happened before. And Dr. Crichton said it better, as one might expect. And so in her writings, she notes that the goal redefinition did not start until the federal government raised questions in the 70s about what it was paying for. Very similar to the conversation that's happening today. And she notes in her work that it had become very, very clear in the 80s that the old boundaries within the medical system and between that system and other support systems, such as income support and shelter, would have to be modified if progress were to be made. And I think it's worth noting that this context in which she's writing is the context that led to the Canada Health Act, one of the most important pieces of legislation that reaffirmed our commitment to be able to facilitate reasonable access without financial barriers and laid out the 5 conditions under which the provinces would continue to receive funding. So this context that Dr. Crichton is writing about, which feels very familiar, led to major legislative change that reaffirmed the structure of the healthcare system. So Dr. Crichton even mused on the same question as I think we have heard in the media, perhaps said in slightly different words, as we are having right now. So she muses in her writing, where does Canada go from here? Is the nation still committed to developing a collectivist healthcare system? It would appear so. And she's asked this question, and I think we've heard this question repeatedly asked as we're in the middle of debating the flurry of private delivery and for-profit debate. So what could we do? I think this agreeing on a goal is a really crucial part of us stepping forward. There's many different frameworks, methodological approaches, guidelines about how we could undertake the work of agreeing on a goal for our healthcare system, which is incredibly lofty. But all of them, importantly, start with listening to the communities whom the system is intended to serve. The last time that this was done was in the Romano Commission, so 2002-ish. Citizens across the country, coast to coast to coast, were brought together in deliberative dialogues. And they were asked to work through their conflicting values and face difficult choices about how the healthcare system could be restructured into what was then a crisis similar to the one that we're in now. And so the participants were asked to weigh up 4 different scenarios. The first was more public investment in doctors, nurses, and equipment, either through tax increases or by reallocation of funds. The second was a form of private payment for healthcare that proposed a system of co-payments by users for all encounters within the healthcare system, so co-payments for seeing your physicians and your hospital care. The third was restructuring of the healthcare system to create a parallel private system, and here they meant private pay and private delivery. And the fourth was an internal restructuring to reorganize the service delivery, whereby Canadians would sign up to some kind of healthcare provider network, again, focusing on, in our language today, what we would call attachment to primary care. And picking up on my Len's points yesterday, it wasn't conceptualized as attachment to a primary care physician, but attachment to primary care in a more general concept. So there was a great deliberation, and there's multiple reports written that I invite you to read. But the results of these deliberations really highlighted that when asked these very tough questions, the public has a lot to say. And they can say it very eloquently, and they can say it in a useful, actionable way. And at the time, this was groundbreaking because there was this paternalistic sort of thought around the public can't engage with these tough questions. They can't grapple with these issues. And so this really challenged that notion and reaffirmed that indeed the public can engage with this and can give us very, very useful, important output. And I would argue that that's still contested today. So I think that this is our first step. We need to listen to Canadians, ask them how they want their system to look, and then take that back into any kind of reform that we want to take about. So let's agree that we can kind of come up with some sort of a goal here, undertake this work. And I'm going to shift gears now and really talk about data in this concept. For me, because I lack imagination, I cannot conceptualize any framework of value that doesn't include some measure of costs and some measure of benefit. And so I think for us, when we think about being a value-based healthcare system, one of the key components is being able to measure what you're trying to achieve. So if we're trying to achieve value-based healthcare, we need to be able to measure value, which for me means we need to be able to measure costs and measure benefit. Two things that we cannot do robustly in our data infrastructure and systems right now. So thinking about measuring costs, we currently have two main methodological ways of doing this in Canada. So the first is a grouper approach, so kind of conceptualized by this group of, I think they're penguins. And in this, what we do is we group similar-like encounters with the hospital system into 522 different categories. And then we assign group-based costs for all of the people that are captured in that kind of net. So what that says is that for people who are assigned the same grouper code, so caught in the same group, they're all assigned the same average cost. And so you can imagine that for some patients, they come in, they're caught in this group, and they might have a very uncomplicated course of care, better than expected. Perhaps they're released from hospital earlier than the average person. On the other hand, you'll have patients who have very complex courses of care. They end up staying in hospital longer, using more resources, which costs us more in the system. At the moment, with this kind of costing methodology and the data that we have, we cannot disentangle those two experiences. We only have data on the average kind of cost. The other way is an individualistic approach called microcosting approach, where a patient's journey is tracked and resources are allocated to them as they progress through that different journey. So this produces an individual level patient profile on costs. As you can imagine, quite labor intensive to produce this data, but we do have pockets of excellence doing that in Canada, and it's continuing to grow. And I would argue that unless we're prepared to invest in some kind of robust costing data measurement system, our pursuit of value is going to be quite limited because we're never going to get a good handle on the costing side of this value metric. Thinking about the benefits side of the house. So again, I'm not saying we'll necessarily agree on how to measure this. I've just put 5 different kinds of things that I think should be in the benefit metrics. So the clinical events, and actually we're pretty good at tracking and measuring in a robust, comprehensive way clinical encounters that involve healthcare physicians specifically. So we're pretty good at tracking when someone is hospitalized, when someone dies, when someone sees a primary care doc. We're pretty good at tracking that in a very, very comprehensive way. But as you can imagine, there's lots of things that are of important when we're thinking about that value equation that aren't captured by that kind of system. And there's many outcomes, as we heard yesterday, that matter a lot to patients and to the system and to providers that we're not tracking in a routine way. There's pockets of excellence doing all sorts of these data collections in different places, but nothing at a large scale that's happening in a systematic way. And so thinking about how we could measure each of these different outcomes is going to be crucial if we want to move forward with benefit. So thinking about some actions, thinking about what we could do, and thinking about how everybody could be involved in sort of advancing this data case. First, of course, I think we need decision makers and policymakers to make the commitment to evidence-informed decision making. And then they need to require data at the tables where they're making decisions. This is a big ask. I completely appreciate that. And I think often one of the things that we fall into is that we need to make the decision now, and we don't have the data now, and it's going to take some time to get it. And so I think there's some really good lessons in that in terms of, at the bedside, completely different story. But at the government, I think there's probably very few cases where you didn't have enough line of sight to be able to buy yourself a week to get some kind of data. And so I think actually standing our ground on this could really push this forward and create some pressure so that we have to move forward on this data agenda. Of course, I have to throw in there, invest, 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 right? The researcher in me needs that, we need the money, we need to do that. So thinking about the researchers, we have a lot of data out there already. Let's use it. I think we often forget how it's imperfect, but maybe it's good enough, close enough. And so let's use the data that we already invest a lot of money in gathering and get the value out of that. I think importantly, we can share our data and our estimates. Again, there's pockets of excellence that are gathering these pieces of data in small ways, and we need to be able to share that better across the community so that we're not reproducing things repeatedly across the country. Co-designing to create and improve the tools for measurement here, and then focus on that sustainability piece of the pilot projects that are being collected. It was said yesterday, Canada is known to be a land of dead pilot projects, and I think really focusing on not letting that happen could advance us here. For healthcare practitioners, expect data, use data, input the data. That, I think, where the data collection is most likely to happen is at the bedside. And so we're going to need both practitioners and the patients who are willing to give us some of their time to get this data into databases that we can then use. And then for the patients and the public, same thing. Expect data, get involved with co-design, share what's important to you so that these metrics reflect the value that you want to see, and then vote with your support. I think it's an imperfect tool, and we'll talk about that a little bit more later, but I think really that's the only way that the loop is closed with the public, and in terms of accountability for this is through that voting mechanism. So I've put out there that we need to have a shared goal that we're trying to pursue, that we need some data structures to be able to do that so that we can actually track our progress towards this goal. And now I'm going to turn to what do we need to kind of just get on with this. So I'm going to do a little bit of a voting poll, and I'm going to ask you to raise your hand for the answer that resonates most with you. You can only vote once. So I'm going to ask the question of whose responsibility is achieving value in the system. So who thinks it's number A, healthcare organization executives? One person. 2, 3, perfect. Okay, the Provincial Minister of Health. Okay, so about like maybe 20% of the room. Okay, the Federal Minister of Health. It's maybe 5%. Okay, and the members of the public. Okay, like more than C, but less than B. Awesome. And so I think, again, just recognizing you're a systematically biased sample, we don't have any agreement on whose accountability value should be or is in the system. And really, if we're going to pursue this, it needs to be someone's accountability, however it's measured. And I know we heard yesterday, someone asked Scott whose responsibility it was, and he said everybody's. And I can understand that on the action side in terms of everybody contributing towards having value in the system. But when everybody is responsible, no one is responsible. And so we need somebody who is accountable. And that's the only way I think we're going to see major strides here. And I completely understand why nobody wants to step up and say, hey, this is my responsibility. There's a lot of risk. And there's a lot of exposure in saying that. We might not do very well here. But so whose responsibility should it be is one of a lot of debate. And I think personally, the federal government needs to step in here. They hold the purse for some of the funding, and they set the terms for how the provinces are going to receive this funding. And so that to me says that they need to step in and take some accountability for this. And we've seen small strides in this area with some of the bilateral agreements that we saw in the 2017 health accords and then more recently in the agreements of a few weeks ago. The provinces have, of course, made it very clear that they don't want the federal government interfering in this, in quotation marks. But again, given how much money goes into this from the feds, I think it's pretty unreasonable that the provinces would expect the feds to hand over that money with no strings attached and no possibility of accountability back. So we heard it from John yesterday. I think the approach of tight, loose, tight works really well here. The feds need to be very tight on the accountability for the money going in, very, very loose on how the provinces operationalize that accountability, and very tight on the metrics that they're going to be using to measure against the value for the investments that they're making. And at the end of the day, money is an incredibly powerful tool. And so I think with the feds putting that much money on the table, the provinces are going to complain, they're going to say that there's interfering, they don't want to go, but at the end of the day, the money on the table is too much to be left behind. And the provinces, as we're seeing now, will come to the table in agreement with this. So coming back to Dr. Crichton's work, collaboration is going to be so needed here. And this is a quote from Dr. Su in explaining why he wanted to invest this inaugural lecture. And he notes that one of the key takeaways from Dr. Crichton's teaching is that a rational healthcare planning from an ivory tower is seldom successful. And I think that would probably resonate with everybody in the room. Collaboration is so needed here. And we're seeing some fantastic pushes through organizations like CIHR who are requiring collaborative and quadripartite teams to come to the table for their funding opportunity. But importantly, the community is demanding this. They no longer want to be left out of these conversations, and collaboration is the way forward. So faced with these kinds of conclusions, what did Dr. Crichton conclude? And again, I'm going to read to you from one of her papers in her conclusion of where the Canadian healthcare system was now. We concluded that the slow negotiations for change towards collectivism had made it difficult for those employed by the healthcare system and for the public to understand the concept of comprehensive healthcare system framework. Nevertheless, there were very strong resistances to change. Transformational development seemed to be restricted to the directly funded public sectors through hospitals are now being forced to consider more cooperation with community-based organizations. The resistances by the medical profession to change are so strong that we wondered whether Canada had decided to settle for a dual system of care, individualistic, subsidized entrepreneurialism for medical services, and collectivism for publicly administered health services. The boundaries of the healthcare system are still unclear because experts have so far been quite successful in excluding consumers from the discussion and decision-making. However, it's coming to be recognized that medical care and public health services cannot provide sufficient supports to the chronic sick, disabled, and frail without community involvement. So faced with these conclusions, what was Dr. Crichton's action? Well, she turned around and she committed to building what is now the Masters of Healthcare Administration out of UBC, which is a flagship training program, groundbreaking at the time, that really thought about how can we train healthcare professionals of the future in a different way. And I want to leave you with a final inspiration. And this is a quote from Dr. Piper. And I'll just share the story behind this quote because it's a bit of a strange quote, perhaps. There was a leadership training event at the University of Calgary a couple of weeks ago with Dr. Piper, and she was talking about her reflections of her time as the president of UBC, where she was the first and remains the only woman president of UBC. And someone in the audience said, you know, I'm in a leadership position and I'm daunted. What would your advice be as we're looking at this future that is hard and like we're not very well equipped to deal with? And she said, this future is no harder than any other future. Every leader sort of looks at their time and is daunted, hopefully, by what they're trying to achieve and is unsure. And the same things are required at every point in time: nerve and courage. Take the action. Thank you very much.